I am Wayne Tuckson. I have the pleasure of being the moderator for part one of a two-part program that will conclude tomorrow morning on protecting health equity in kidney care, a community conversation, ensuring access to life-saving end-stage renal disease, oral-only medicines within medical care. We're being hosted here at the Calvary District Church of God in Christ with Superintendent Walter Fields Jr. is the pastor. Having said that about that form, there is a form we want you to fill out. And I promise you it's not the same. There is a pre-program evaluation we'd like you all to fill out. And you can also fill it out online for those of you that are joining us online, and welcome to you also. The real question comes down to, why is this program here? Why are we doing this? Why is Pastor Fields hosting a program on end-stage renal disease? And the answer is really quite simple. African Americans have 3 times the rate of end-stage renal disease compared to whites in the United States. There are 2 leading causes of end-stage renal disease, of which we also have the leading incidence of these. That's diabetes and hypertension. Now, it's true that genetics may play a role in the higher incidence rates in African Americans, but I will posit that the higher rates of renal disease are not a consequence of some genetic and or inherent predisposition to poor health in African Americans. Rather, it is the expected result of deliberate de facto social policy and de jure political and or legal policies, which we've all seen the effects of. As we shall also see, African Americans not only have an increased incidence of end-stage renal disease, but we also see discrimination in the diagnosis and access to effective state-of-the-art treatments. And this includes both medical management of the disease and its complications associated with renal disease and surgical treatment, namely transplantation. We will also hear about the role that diet can play in affecting our risk and exacerbating the complications of renal disease. However, through careful food choices, we will see that we can still have a plate that satisfies our palates while sensibly help managing end-stage renal disease. At the end of tonight's program, we will have a call to action, not to take a partisan position before the recent gathering or after this recent gathering of pitchforks and torches fades away. I want everyone to ask yourself, when we listen to what was discussed on the floor of the convention, how many of us heard about improvements that are things addressing our needs? Talk about access to quality foods, access to health care, decreasing our exposure to adverse events that contribute to our problems as far as end-stage renal disease and other illnesses that affect the African American community. Finally, at the end of our discussion, we'll be talking about other things, and I want to go over again about the programs and things that we can do to make things better for ourselves. So to get things started, as I said, tonight's program is hosted here at Calvary District Church of God in Christ, and the superintendent, Reverend Walter L. Fields Jr. is the pastor. He'll now give us greetings and open the program.
Thank you, first of all, everyone, for being here. I am so appreciative to have the opportunity to share in this informational session. It's a joy to partner and to come together and to learn learn from initiatives that will benefit our people. Oftentimes, we fail to learn and to gather information, and then we fail to succeed in areas where we can. Since we're in the St. Paul Church of God in Christ, and we are the Calvary District, we will say, lift a quote from the scriptures, which says that people perish because of the lack of knowledge. And I believe that in this season that we're in, that it's very important for us to know what we're dealing with, know how we can address it, and how also we can correct it. And so we're overjoyed with the HEAL Collaborative and all those that are connected and who have elected to come to Milwaukee. Thank you let's praise God for them coming to Milwaukee. And even beyond that, we thank you for choosing us, a church that's affixed right in the middle of the community, the African American community, those who are suffering from issues and circumstances such as these, and coming here and sharing this information with us. I do also want to give acknowledgement to the woman in our Calvary district who stands by my side to ensure that our reach to the community is expanded the way that it is, and that is Dr. Evangelist Aura McGahee. She's here. And so there's so many that have registered and they're coming in slowly but surely, but we're here and we want to know all that we can know about this initiative and how we can be individuals who live healthy lifestyles. So thank you again for coming and partnering with us. We are overjoyed and privileged to have you in this place today. Thank you. Yes. And as they are preparing to serve food, I think it's only proper and befitting that we bless it. And so please bow your heads for a moment. Father, we are grateful for the food that we are about to eat. We thank you for the hands that have prepared it, and we pray that if there be any impurities, you remove them now. And God, that you let this food be nourishment to our bodies, and all the nourishment that we receive, let it be returned to you in service. And we pray these things in the name of Jesus Christ. Thank God and amen. Thank you.
And please forgive my faux pas. I can't blame it on jet lag. I blame it on driving lag. Next, we have greetings from Howard Mosley. He's the corporate treasurer for Heal Collaborative. Mr. Mosley is a former Georgia state representative. And as I said, he is the corporate treasurer for Heal. Mr. Mosley.
Good afternoon. Get closer to the mic. Good afternoon. So I don't have a joke, which is a good thing. All right, so Superintendent Fields, first of all, thank you for allowing us to come into your house. This is important information that we want to provide to this community, and that you open your doors so that your congregation and the communities you serve get this important information. And it is important that we do this here. And as we talked earlier, I just want you to know that this is truly ministry work for us. So thank you all. Thank you for letting us do that. It is not by accident that the foundation of HEAL's approach to engagement is our collaborative service to communities of color. Partnering with Ardelyx on its commitment on health equity has given us the opportunity to change the status quo on how and by whom trusted health information is presented to communities of color. We recognize that each community as having value, a unique culture, and varying health challenges. Healing within a community happens the moment where service meets commitment. Healthcare systems provide life-saving services to citizens within those local communities. Medical experts within these healthcare systems provide care to local citizens who relied on that medical expertise, interventions, treatment, innovations, mental health, and behavioral support. But our programs, HEAL's programs, have helped bridge those gaps by bringing those committed healthcare experts into this collaborative to bring this information to repair this breach. We're excited about the work that we're doing in chronic kidney disease. How many of you know where a dialysis center is? You've seen them. What's around a dialysis center? I can tell you right quick. Look. It is all, if you see the things that sit around a dialysis center, it should tell you real quickly that there are some policy issues that we need to address to change the trajectory of what's happening in this space. So we're excited about this work. The health equity narrative has changed, and those who are to be recognized for repairing this breach are the local community of pastors, patients, caregivers, community leaders, and advocates. Your advocacy right now is the secret sauce that makes a difference about political, social, economic, and policy health changes this community wants to see. We believe that healthcare is the best place to start. So lean forward, please engage, take notes, ask questions. This is a safe space for you to ask the questions that you want to get answered, and we will have trusted experts here to be able to answer those questions. Thank you for attending, and we look forward to having a great program. Thank you very much.
To that point about asking questions, there will be, after each of the speakers, we're going to hear each one, and then we'll have a panel discussion, and that is a time where you can ask questions. So as you're listening to the various speakers, please jot down to yourself or try to remember if you can, so that you can ask the appropriate questions. For those of you who are online, if you could just send your questions in, we'll also have a chance to get them at that time also. Again, I want to remind you, if you haven't done so already, to please fill out the pre-program evaluation, because at the end of the program, we're going to have you fill out a post-program evaluation. Next, our speaker to give us greetings is the Reverend Dr. Alan Ryan. Dr. Ryan is the Senior Director, Patient Advocacy at Artilex. Dr. Ryan several of our speakers will be coming to us by Zoom. So Dr. Ryan, take the floor.
Good evening, my brothers and sisters. I wish I could be there today, but apparently that was not meant to be, given what happened with all of the technology challenges across the globe today. I live in Atlanta. And there wasn't much moving out of Atlanta. My flight in particular was canceled, but I really wish I could be there. One of my favorite things to do is come to a Kojic worship service. I know you're going to have a worship service after this session, and I was looking forward to attending that with you all. I'm just grateful that our company, Ardelyx, is able to partner with organizations like HEAL, who have a vision to make sure that good health information is reaching our community. I'm delighted that Pastor Fields thought it not robbery to partner with HEAL, and his vision is big enough to include making sure that his people have good information for health. It's really a joy and such an encouraging thing when our pastors are doing that kind of work. It's not a given, and so we appreciate and value the opportunity for our organization to partner with HEAL and with the St. Paul Kojic Church. And so we look forward to continuing the conversation. I'm sure everyone will have a great dinner and a great session. And we're just glad to be here, even if virtually. Thank you.
Because one of our speakers is another Howard person, so it's always good to have when Howard people can get together. It has been my experience, and I think is probably the same experience that Dr. Williams, from whom you'll be hearing a little bit later, that patients will oftentimes listen to the physician, but they hear what patients and family members and others tell them. So they kind of listen to what the doctor says, but they really won't talk to their friends to find out what the real skinny is about what we're talking about. Seems that the patient experience is more the gospel than the physician is not quite telling it all. It always seems to be we're not telling the whole truth. Well, to give us the word, we have Ms. Lisa Parker, who will give us a dialysis patient's perspective. Ms. Parker will share her experiences as a kidney warrior and a patient living with hyperphosphatemia. Ms. Parker.
Hi, Milwaukee. I am so sorry that I am not there in person to meet you all. I am Lisa Parker, and I am a kidney patient on dialysis with hyperphosphatemia. And I want to tell you that it's been a long journey. I started December of 2019. About a month before that, I was extremely sick. Didn't know what was going on. Was at a Sam's Club trying to shop, and I became extremely tired. And of course, before this time, I was tired on different days. And I was thinking, oh, I'm just not exercising. I need to exercise more. I need to do this more, things like that. But little did I know that I had kidney disease. And when I had to go to the hospital in November of 2019 from passing out at Sam's, I realized that this kidney disease was something very serious. And I was already basically at stage 5. So a month later, they put me on dialysis. And I was so shocked. And it changed my whole world around. And during that time, of course, I said December of 2019, 2020 came along. And guess what happened? COVID happened. So basically, my job being an administrator over a real estate school ended. I had no work. I had nothing, disability, nothing. I could not work because I was going to dialysis on Monday, Wednesdays, and Fridays. And it's really hard for people to adjust, but some people do, some jobs do, but my job was closed because I was at a school. It became very hard on my family. And so basically, I got into a depression, a really deep depression. The depression came from me having to go to dialysis 3 days a week and not understanding what's going on with me. Not only with kidney disease, but with the going to dialysis where you have to sit down and have your needles in you. Your blood pressure go up sometimes it goes low. And we just don't know. I did not know what was going on during the time. Well, throughout this time, I'm beginning to itch, itching around my skin area, itching, having some type of pain in my stomach, and found out that I need to take my binders because I have a lot of phosphorus inside of me, which is where hyperphosphatemia comes from. I was so miserable in the middle of the night, just itching, feeling something was crawling on me, having different types of pains. It can affect your bones. It can affect different organs in your body, especially your blood in your veins. Calcium can stop your blood from flowing. So it's really, really important, if that happens, or if you know someone who has dialysis, to take their binders, take the medication that's needed to stop the phosphorus from staying in your body. I want to tell you that I really went into a deep depression, and I definitely had one suicidal thought. And because of that one suicidal thought, that made me become an advocate for kidney disease. That made me pray more. And with God delivering me from those thoughts, I was able to talk to my doctor, advocate for myself, tell my doctor what's going on. Because at first I was scared, but at first it was like being treated like a child, having been told where to go, what time to be there at the clinic, having these charts on how well my blood is, how well my urine is, how well my phosphorus is, how well my protein is. So there's about 8 different things that they test for about once or twice a month. And so they always come to you and tell you what you did or did not do. And so those things were overwhelming for me. And besides the fact that I do have a life outside of dialysis, but that was hindering my life outside of dialysis also. But once I started advocating, once I started really learning about kidney disease everything has gotten so much better. Because technically, the dialysis does help me. It helps me stay alive. And I'm grateful for God for all of that. But I want you, if you have any type of feelings in your body and you're thinking, oh, it'll go away, things like that, please go to your doctor. Please, if you hear a loved one or a friend say anything about their body, especially if they're tired, especially if they want to drink water a lot, or, they really can't function, they need to go to the doctor. I want everyone to understand that kidney disease is very dangerous for a person to go through. And I just don't want that happening to anyone. And just think about it. If you are going through something like this and you're feeling down, like you don't know how to get through it, understand that God is there for you. And if you understand that, you will know He will find a way for you to get through it, like He's done for me. I always think about this. God didn't make the Red Sea disappear. He parted it so people can get through. And I thank you so much for listening to me this evening. You all take care.
Thank you very much, Ms. Parker. And I'm sure many of you will have questions and want to maybe even probe her a little bit more about her experiences. Again, at the end of our speakers, we'll have a chance for a panel discussion about that. Next, let us bring up our keynote speaker, Dr. Laura Williams. Dr. Williams is a graduate of the Ray J. and Lucille A. Carver College of Medicine at the University of Iowa. She completed a residency in internal medicine at the University of Michigan Health System, followed by a fellowship in infectious disease and a master's in public health and epidemiology at the University of Washington. She has held multiple positions in the biotech industry and is currently the chief medical officer at Ardelyx. Dr. Williams will speak to us about protecting patients' access to end-stage renal disease oral medicines within Medicare. Dr. Williams, we're looking forward to hearing your comments.
Thanks, Dr. Tuckson. This is great to be with you guys. I was glad when they said unto me, "Let us go into the house of the Lord." I really am grateful to you all for allowing us to come and to share from an educational standpoint, background information as it relates to chronic kidney disease, an issue as it relates to healthcare policy that we think is really important. So really want to, again, say thank you to Superintendent Fields and St. Paul Kojic. Apologies, along with my other colleagues. Was at the airport for 4 hours trying to get there, and it became obvious that that wasn't going to happen. And things happen for a reason. It was not God's will. So happy to be here, obviously, virtually. I'll start with just telling you a little bit about Ardelyx. We are a small biotech company located just outside of Boston. And, our mission has always been to discover and to develop and to commercialize drugs that actually matter, drugs that address real unmet medical need, innovative drugs, not me too drugs, but drugs that are new and are actually tackling an issue or a problem, truly addressing an unmet need. And so one of the things that, again, we work right now, or we focus in a couple of therapeutic areas. One is GI or gastroenterology, and the other one is kidney disease. And so what I want to go through tonight is to walk you through a little bit in terms of just background, talk a little bit about the policy issue, and leave you with, sort of the solution, or what we think is part of the solution, and a little bit about what you might be able to do to help with that. So with that, I'm going to I'm going to start. I'm going to share my screen, and you guys let me know if you see them and everything is okay. Everybody good? Can't really hear the response, but I'm assuming that you see them. Somebody will stop me if you don't. So first of all, we talked a little bit already about social determinants of health. I mean, again, this is sort of the crux of the issue, and I really I think tonight's talk really focuses on a key one, which is policy and law. But all of these things actually have a big role in health outcomes, right? So where you live, um, where you work, if you have access to health care, what's your social network, um, the food you eat, where are you located, what kind of access to food do you have? You live in a food desert. Um, how much education you have. All of those things play a role in terms of health outcomes. And when I talk about outcomes, I mean um, life expectancy, mortality, so death, illness, that's morbidity, all of those sorts of things. And I think policy is sometimes overlooked, and that's what we're going to focus on a little bit today. But before I jump into that, I want to talk to you with through the lens of just chronic kidney disease and give you a little bit of background. So it's a big deal, right? I mean, nearly 37 million Americans have chronic kidney disease, and almost 90% of them don't know that they have it, right? So 9 out of 10 people actually in the US have chronic kidney disease, but they don't know they have it. And similar to what Ms. Parker just, talked about in terms of sort of crashing into dialysis, not even knowing that she had chronic kidney disease before that progressed to end-stage kidney disease or kidney failure. Although diabetes and hypertension are the most common causes, there are also some unknown causes. And as Dr. Tuckson alluded to, certainly genetics can play a role in sort of the disproportionate rate, but that's not the only reason. Obviously, diabetes, hypertension, number one and number two, and those also have disproportionate rates of prevalence in minoritized populations. A newer classification is called CKD of non-traditional origin. And this includes, folks who are actually, agricultural workers, construction workers, basically exposed to hot environments, working in those environments for long periods of time. And that's likely related to, again, heat, toxins, infection, but being in the heat for long periods of time, it causes repeated bouts of dehydration that eventually affect the kidney. Now, in terms of treatment, really, I mean, before we get to treatment though, 37 million Americans have chronic kidney disease, and about 800,000 actually have progressed to kidney failure. We call it end-stage renal disease, end-stage kidney disease, kidney failure, right? And the only treatment really is renal replacement therapy, and that comes in two forms, either dialysis, and that's about 2/3 of patients, or a kidney transplant, and that's 1/3 of patients. And dialysis organizations, they can be large, small, or independent. They're the mainstay of dialysis services. And so when you have a dialysis service, that usually includes the dialysis itself, medications that are given during a dialysis session, the labs, the blood work that's needed, and any supplies, as well as the staff who are taking care of those patients. As already alluded to, Blacks and non-white Hispanics are disproportionately affected with kidney failure, with a 4-fold and a 2.5-fold higher rate, respectively. So Blacks, 4-fold higher rate, non-white Hispanics, 2.5-fold higher rates than whites. And despite that disproportionality, 1.6 to 2.5 times higher rates of transplants happen in whites versus Blacks and non-white Hispanics. And by the way, transplant really is the best or provides the best mode of treatment in terms of just long-term survival. So now let's talk about what happens in terms of treatment of these patients. Well, Medicare has been the primary payer for patients with kidney failure in the US since 1972, with additional, work being, additional sort of things added to the model in 1983. But eventually, in 2011, I should step back. All of that was previously done as a fee for service, sort of payment. So whatever, the dialysis organization or the dialysis center did for that patient, they would then bill the government and they would get paid. So that's fee for service. But in 2011, the government said no. We're actually spending a lot of money, and we want to, change this system to what we call a bundle system, or the official name is end-stage renal disease prospective payment system, but that's a mouthful. That basically means a fixed payment, or a bundle. So all of those things that happen when a patient sits in the dialysis chair, instead of you billing individually for each of those things, you're going to get a fixed amount. Let's say that's $250. That $250 has to pay for the dialysis. When you sit in that chair, it's got to pay for any medications that have to be given during dialysis, any lab work, blood work that's done, any equipment, and the staff that takes care of the patients. And that was fine, I think, for a while, and it was fine for certain treatments, but it is now an antiquated, inadequate service that is not optimal from a patient care standpoint. And this is an example, my friends, of a policy that has become a social determinant of health. And we're going to talk a lot more about that as we go forward. This is just a busy slide that talks about that CKD of non-traditional origin. And there was a nice Times article on chronic kidney disease as it relates to climate change. And this was a picture of a construction worker tolling in very heat in a very heated environment in Georgia, and this was last year. But again, that's another cause, and these are typically younger men. They don't have diabetes or hypertension. This is really being exposed for too long of a period of time in the sun. And as a youngest of 14, having been born in Mississippi on a plantation to parents who were sharecroppers, I'm sure that there was a lot of this that happened, but we didn't have records, right? Because there was no access to care. All right, this is a busy slide. At the end of the day, we've talked about a little bit of the background. This slide is meant to tell you some of the complications, and it's a busy, very detailed slide, but at the end of the day, there are some major complications of chronic kidney disease. One is anemia, right? Because there's a protein that is made by the kidney that once the kidneys fail, no longer makes it. And so that protein is responsible for producing red blood cells. And so when you don't get that, your hemoglobin, your hematocrit drops, there's fatigue, there's weakness, and there's other complications associated with it. Another big one is really a constellation of issues. And it includes calcium, phosphorus, and another, issue called parathyroidism. It's a very, long name, but at the end of the day, these three things together, high calcium, high phosphorus, high parathyroid hormone, really constitutes what we call chronic kidney disease, mineral bone disorder. And even though it's called mineral bone disorder, it's associated with more than just bone disease. It's associated with heart disease. It's associated with increased mortality due to heart disease. It's associated with amputations, all of those things. And so I won't go through the details, but those are some of the key complications. Clearly, there's other things like fluid overload, high blood pressure, a weakening of the immune system, all of those things. And of all of the complications, really, what I want to get to is the fact that elevated serum phosphorus, and you heard a little bit about it already, is probably the worst of all of those things. And why does that happen? Well, normally, when you have normal kidney function, you take in the phosphorus that you take in your diet, and you just had some with your meal. Anytime you eat, it's there because it's ubiquitous. It's in good food, it's in processed food. So it's in nuts, it's in dairy, it's in cheese, it's in meat, it's in, it is truly ubiquitous, but it's also high in content in processed foods. And so when you take that in, most of that is actually excreted by the kidneys. And so when the kidneys fail, if you look down here, phosphorus levels build up. And why is that a problem? And that's what the next slide sort of speaks to. More so than any of the other things that we talked about in terms of complications, hyperphosphatemia, an elevated phosphorus level, carries with it more mortality risk than any of those things. 2 times more than anemia, 3 times more than elevated calcium. It is a big deal. And here's why it's a big deal. With every increase, and so that blue bar is the normal range. So with every increase in serum phosphorus, there is an increased risk of death. So with every milligram increase, I should say, there's an increased risk of death. And this is a highly prevalent complication in patients who are on maintenance dialysis. Almost every patient who has, kidney failure and are on maintenance dialysis gets to a point where they have elevated serum phosphorus. And why is that problematic? The phosphorus binds to the calcium that's in your bloodstream, and it deposits in blood vessels. And that's what causes blockages, so heart disease, heart attacks, strokes. That's also what causes, again, loss of limbs, so amputations, those sorts of things. So there's both an increase in morbidity and mortality as it relates to serum phosphorus. So again, more problematic than any of the other complications that happen. And these are just pictures of what happens when phosphorus binds with calcium and builds up in the blood. And I won't go through these in a lot of detail, but these are all patients who are on dialysis, varying ages. This is a 59-year-old patient. And this is where the arrow points out is this is just calcium and phosphorus deposits along the aorta, which is the biggest blood vessel in the body. That blood goes to the heart and then it gets pumped out to the rest of the body. This is a person who's got calcification in all of the vessels, all of the blood vessels that support the heart. So this is heart disease as a result of, again, the calcification because of the buildup of phosphorus and calcium. And then this is a patient, 65-year-old patient, again, on dialysis, who you can just see this is a blood vessel behind the knee that runs up all the way along the leg. And this is completely, the fact that it's lit up, you're not supposed to see this on an x-ray. The fact that you see all of these things on an x-ray or another imaging tool means that there is deposits. This patient is at risk for losing a limb. And so it is problematic. And that is why we have guidelines that tell us that we should try to maintain serum phosphorus toward the normal range. There are international guidelines that tell us that, and then there are local guidelines that tell us that. And so that is the goal. And so how do you do that? Well, there are a couple of ways in terms of non-pharmacologic, so non-medical ways to do it. One is that we often tell patients, well, you can try to reduce the amount of phosphorus that you take into your diet. So, you know, that sounds great, and I don't knock it. I mean, diet is a very important thing. But I think we also have to be cognizant of the fact that a lot of our patients live in food deserts. And so, you know, you can say restrict those processed foods. But again, they're everywhere. And that may be the only thing that patients have access to, because again, a number of folks live in food deserts. And it also may be complicated by the fact that there are other dietary restrictions because of, you know, comorbidities with diabetes or high blood pressure or elevated cholesterol. But diet is certainly something that we recommend in terms of a non-pharmacological treatment approach. The other thing you could do is maybe you could increase the frequency or extend duration of hemodialysis. For example, patients who are actually on home dialysis tend to have lower phosphorus levels because they can dialyze overnight and they can dialyze for a longer period of times. But most of our patients are actually in-center dialysis patients. In other words, they go to those dialysis centers that were mentioned earlier, and they go 3 times a week, at least 3 hours a session. And so asking them to increase the frequency is just really not practical. Not only is it not practical in terms of the burden that it puts on patients, it's not logistically practical from a dialysis provider perspective. And so when you look at these non-pharmacological treatment approaches, yep, that's great. You know, when I think about renal replacement therapy, the order in terms of what's best is a transplant. What's next best is home dialysis, and then in-center dialysis. And so, again, nice sort of things to mention, but neither, well, certainly this one is not practical. So that brings us to sort of what we can do from a medical standpoint, from a treatment standpoint, from a drug standpoint. Most patients, about 80% of them, until recently, were on phosphate binders. And just like the name implies, these are drugs that you take by mouth, and they bind the phosphorus that you take in through your diet. So you take them usually 3 times a day with every meal and snack. And some people take 2 types of binders. And so when you think about that, that's problematic because the median daily dose of phosphate binders is about 9 pills. So that doesn't even take into account all of the other drugs that they take for their other medical problems. And so when you think about adding binders to all of the other drugs that they have, then the overall pill burden, so binders plus everything else they have, is about 19 tablets a day. I don't know anybody that can be compliant with taking that many pills every day. But this is what we ask our dialysis patients to do. And so, again, for the longest time, for like 50 years, phosphate binders were the only thing, and from a medication standpoint, that we could use to lower serum phosphorus. And that was until, you know, October of last year when a drug that we developed actually got approved. And I'll talk about it in just a little bit. But this is the 50-year sort of timeline of all of the different phosphate binders. And they all do the same thing. You all take them, you take them by mouth with a meal. And again, as I said, the median number of phosphate binders a day that any given patient takes is about 9. This new drug, instead of a binder, it is a phosphate blocker or a phosphate inhibitor. So instead of binding, it blocks phosphorus from being absorbed into the gut. And so that's the nice thing about it. I mean, most of our phosphorus that we take in our diet, it actually is absorbed through the paracellular pathway. And so in a patient who's on dialysis and has elevated phosphorus, without this new drug called Exfosa, phosphorus just passes through from the gut into the bloodstream, and that's why the phosphate levels go up. But with exposure, because it blocks this absorption, the space between the cells get tighter, right? They get closer, and so the phosphorus cannot get through, and that's great because then the phosphorus levels in the blood are lowered. So that's nice because what happens now is that you've got a simplified dosing regimen. It's basically fewer and smaller pills. You take one pill twice a day with the 2 largest meals per day. We think that's innovative. And so that's the background information. Now let's get to the policy part of it that is problematic. And it's that bundle system that I talked about before. Remember, Medicare has been paying. They've been the primary payer for patients with kidney failure since 1972. In 2011, they overhauled everything and said, look, we're not going to do fee for service anymore. We're going to do a fixed payment. And we're going to only give you a certain amount of dollars, and you figure out how to get all of those things that you need to do for that patient with that fixed amount of dollars. And so what they also said, and it's not here, but what they said in that in 2014, and so most of the drugs that are given during dialysis are drugs that can be given by mouth or they can be injected. But these are drugs that are actually given during a dialysis service. But they said in 2014 that they were also going to move drugs that could only be given by mouth into this bundle system. And so that's what they are planning to do. That is the big deal here. And based on what we have seen with other drugs that have gone into this bundle system, what it effectively does is it actually limits the use of the more innovative drugs. Because, again, if you're only given a set amount, anytime a new drug comes out, obviously it costs more money. And so, when you think about the increase in that fixed payment that happens when a new drug comes about, it's never going to be enough to actually cover the real cost of that new drug. And so what happens is most patients never get to experience the use of these new innovative products. And so they said, look, we did this, or we want to do this. They said, so let me just step back. So this idea now to put even the drugs that are only taken by mouth into the bundle system, basically Congress has said 3 times in the past, that's not a good idea, right? We don't think that serves patients well. And so 3 times in the past, they have blocked the inclusion of oral only drugs like these phosphate lowering therapies from going into the bundle. But the last legislation that was passed to keep these drugs out of the bundle, well, that will expire this year at the end of the year, December 31st. And so starting January 1st, 2025, these phosphate lowering therapies, which first and foremost can't even be given during a dialysis session because you have to take them with food. And generally, patients cannot eat during a dialysis session. So they're not even part of a dialysis session. They shouldn't be part of this. But again, unless Congress acts again for a 4th time, these drugs will go into the bundle, and that will be problematic. Now, CMS, the Centers for Medicare Services, which is, again, the Medicare organization that pays for all of this stuff, they've said, well, yeah, we want to do this. We want to move these drugs from Part D, which is, where dialysis patients get their medications for high blood pressure or diabetes or heart failure, and where they get their medications, their phosphate lowering therapies now. They want to move that from Part D to Part B into the bundle again on January 1st. And they said, we think that that's a good idea for all of these reasons. They said when we did this for another drug, there was a lot more utilization of that drug across all patients, all races, and a significantly more utilization among the Black population. This is their words. They also said, you know, when utilization increased, when people started to use these drugs more, that the cost decreased. And so they're saying that this bundle system actually works, that it helps. And they're stating these things. They also said that, you know, they've been monitoring this and they haven't really seen any adverse outcomes, but they haven't actually shared with us any of those data. So we looked at the data, and quite frankly, none of those reasons actually make sense. They're not supported by data. There was increased use of the drug that they were talking about actually before they even put it in the bundle. And that increase really continued during the period before it actually went into the bundle. But once it went into the bundle, the use was effectively eliminated, because then the dialysis providers had to make a decision. Am I going to use the more costly drug, or am I going to use the cheaper drug? And so they went back to the cheaper drug. So yeah, there was an increase in uptake initially, but that wasn't because of the bundle. In fact, that use was eliminated once those drugs went into the bundle. And this ratio of Blacks to whites in terms of using this type of drug, it was the same before and during the bundle. It was about a 1.7 ratio of Blacks using this type of drug to whites before the bundle and after the bundle. And the reason why that ratio is higher in Blacks is because the drug that they're talking about was treating a disease that is more severe in Blacks and more common in Blacks. So it wasn't, so this was not supported by data. This next fact in terms of costs decreased because basically they stopped using the newer, more innovative drug. And they did that with less favorable outcomes for patients. So they say they've been monitoring outcomes, but what we have seen basically is that there is an increase in surgeries because of worsening outcomes when the more innovative drug was not used. So their data doesn't actually support a benefit of moving these drugs into the bundle. And quite frankly, even the government, when they scored this, they have said, wow, we don't actually see a cost saver in terms of moving these drugs. So there's no reason to move them. And we think patients' outcomes are gonna suffer. So here's the issue with continuing here's why we think you need to continue to exclude these drugs out of the bundle. If they are included into the bundle, these are the undesirable circumstances or consequences that we think will happen. It'll restrict patient access to the newer, more novel therapies. Think about it this way. I mean, 10 years ago, most folks with diabetes, I think the only thing they had, everybody was on metformin. Well, now we know that there are things like Ozempic and Jardiance and Farxiga that get people to a lower, to better diabetic control, lower A1Cs. And what if you only had one mechanism of action to treat this? You would never be able to achieve your target goals. So we think it restricts patient access to these novel treatments, and we think that's a problem. We also think that it takes away that shared decision-making that the patient should have with his or her physician. Because what happens is the dialysis facilities has a protocol that says you're going to get drug X and drug X only. Doesn't matter that your situation might be different and you might need drug X and drug Y or drug Y and drug Z. No, this protocol says you only get this drug. And that's a problem. We also think it's a logistical problem from an operational standpoint, because now the dialysis organizations, those that don't have their own pharmacies, will have to contract with pharmacies to actually provide these medications. And these, again, are medications that they're just dispensing. They're not taken while the patient is actually at dialysis. So for all those reasons, we think that that is problematic. And I think, again, one of the things I will say, the access to novel treatment in this space is really critical because, as I said before, 80% of patients are on phosphate binders. And when you look at their serum phosphorus level over an extended period of time, let's say 6 months, nearly 70 to 75% of them are not at target goal. So they're on a therapy that's not working. And then you deny access to a more novel therapy that has the potential to get them to where they need to be. That is a problem. That is a social determinant of health. So what's the solution? Well, Congress, again, is trying to act. Again, I said they have acted 3 times in the past to delay including these drugs into the bundle. And so there's a legislative effort afoot to continue to exclude these phosphate-lowering therapies out of the bundle. And they come by way of 2 bills, one introduced in the House of Representatives and one introduced by the Senate. And you can see the representatives here who have introduced the bill with a lot of additional support. So there are bills that have already been introduced that now we have to make our voices be heard to make sure that these bills actually get passed. And then you've got organizational support from advocacy groups across the country, and not just advocacy groups. Look at some of these names. Obviously, HIL is here. The Black Labor Union, A. Philip Randolph Institute is here. All of the kidney organizations are here. AAKP, AKF, NKF, American Society of Nephrology. Other organizations like Sickle Cell Foundation, National Baptist Convention, again, and National Minority Quality Forum. I mean, the list is huge. NAACP, New York. Quite frankly, there is no group that's against this effort. Everybody feels like including these drugs into the bundle would be a problem. And so there are a number of labor unions also, because we talked about the impact that it has on construction workers and laborers. So there is just a great amount of support to make sure that we don't allow CMS to do the wrong thing here. And I just now want to pivot, just as I close, in terms of just innovation and sort of the contrasting levels of innovation. When you look at dialysis itself, really, we've had the same sort of system for 50 years. It hasn't really changed since the 70s and the 80s. Now, compare and contrast that to the telephone. I know I remember this rotary dial thing. We used to have one. Everybody remembers the big hunky, cell phone that first came out. Then there was a BlackBerry. Now we got iPhones. I mean, even in drugs, for 50 years, again, phosphate binders. And now we finally have a drug with a different mechanism of action. I think our patients deserve more. When we look at, drug development in this space, it's significantly less in the kidney space. Look at, just FDA approvals from 2015 to 2023 in terms of drugs. If you look at cancer, and of course, you want innovation in these spaces, but I think our patients deserve more as well. 119 to 10. And you look at just, these sobering facts. Again, 37 million Americans have kidney disease. That's about 15%. 3.5 to 4 times more likely to develop kidney failure, African Americans. 110 Americans begin hemodialysis every year. 360 people begin dialysis treatment every 24 hours. And a typical in-center dialysis patient spends 12 hours a week hooked up to a dialysis machine, and 13 people died each day waiting for a transplant. I think our patients deserve better. And so you may be asking now, my dad was a Southern Baptist minister, and at the end of his sermon, sometimes he would say, "What must I do?" And so you're probably asking, what can I do? And here's what you can do. There's a QR code here on the screen. You can actually reach out to your local legislators and urge Washington to work for kidney patients, not against them. And if you click on this QR code, it'll take you right to an actionable item that you can do today. So with that, I am going to stop, and I'm going to stop sharing, or maybe I'll go back to that just to make sure people were able to use their phone and go to the QR code. But with that, I'll turn it back over to you, Dr. Tux.
Thank you very much, Dr. Williams. We began our talk talking about voting. And now you see why it's so important when we talk about voting is healthcare. When we talk about the healthcare things we want to do, eating properly, taking care of ourselves, but also getting involved in the legislative process. So Dr. Williams kind of went through some of the things that are really important for us. By the way, how many people here either A, have renal disease, or have a family member or someone who's close to them that has renal disease? Raise your hands for me, please. All right. Well, you said about a 15%, Dr. Williams, and that's what we're seeing here now. I'm really sorry that you couldn't be here with us today, Dr. Williams, because you missed out on a very good dinner. Though Pastor Fields was able to bless the food, the cooks did, those folks did a great job in the back. So everyone, give a hand to the folks back there. I think that was excellent, excellent. And no, we did not save you any either, Dr. Williams. Our next speaker is Dr. Yvonne Greer. Dr. Greer is a native of Milwaukee. She received her Bachelor of Science degree in dietetics and experimental foods at the University of Wisconsin-Stevens Point, followed by a dietetic internship at Howard University Hospital in Washington, D.C. She received a master's degree in public health from the University of Minnesota School of Public Health, and then she obtained certification as a lactation counselor at the Academy of Lactation and completed her doctorate in public health at Walden University. Dr. Greer is a recognized expert on the Association of Social Connections in Nutrition and Wellness, and for her work, she received the Walden Leadership Excellence Award in 2023. She is now the owner of Why Eat Right, and that's why the letter Y, Eat Right, nutritional consultants for healthy living. Tonight, Dr. Greer is going to explain to us how she combines lactation along with nutrition and kidney disease for a healthy life. Dr. Greer, thank you. Dr. Williams, if you can stop sharing your screen. If you can stop sharing, thank you very much.
Thank you for that introduction. Is this working? Yes, technically I did not say I would be combining lactation and kidney and that type of thing, but definitely that's something that can be done, but I'm not planning on doing that. I'm very happy to be here and honored to be here to talk on this subject, nutrition and kidney disease. I have a title, Healthy Eating for Life, because what we're trying to do is prolong our life, no matter what stage you're at, whether you don't have kidney disease, whether you're developing kidney disease, whether you have end-stage renal disease, you still want to prolong your life. And so when you hear me talk about why eat right, you know, I'm really a public health dietitian that really wants everyone to live long and healthy lives. So could you have the next slide? So I just wanted to go through that. I will be going through my mission moment. Why did I do what I do? Why did I choose this field and how I'm progressing in it. An opening statement. I'm going to talk about kidney health is affected by all body systems and how we have one body that we're trying to take care of. Creating your healthy eating plan, the importance of eating a rainbow of fruits and vegetables and phytochemicals and what those are, and then a word about healthy eating patterns for kidney health, healthy food, soul food makeovers, and how we can actually not have to give up some of our traditional foods and yet still maintain a healthy nutritional profile. And then a few closing remarks. So next slide. I always start my presentations off by having my what I call Why Eat Right mission moment. And I'm not going to go through the whole, usually the long dissertation, because I only have a few minutes to talk, but I wanted to make sure people know that I started my journey in dietetics and nutrition at the age of 12, when my grandmother was taken to the hospital in a coma. She had diabetes. I didn't know what was going on with her. I saw her being wheeled in on a stretcher. But they told about 1 in the morning, she was stable, come back tomorrow. I went back the next day with my mom, and she was sitting up in the bed, smiling, just like nothing ever happened. And I said, well, what in the world? I think the nurse looked at me and she just saw the perplexed look on my face. And she says, oh, honey, she's going to be okay. She's a diabetic. She just has to watch what she eats. And I was like, wow, food can make you like that. So then I went into dietetics, really want to know what happened in the body, and did my undergraduate at UW Stevens Point, and then my internship at Howard University Hospital. And so I'm very proud to be part of the Howard alumni. But one of the things that happened is after I got back, and I'm in my 20s now, my grandmother was having some illness problems, and I said, well, just make sure you take in your fruit servings and your exchanges for your bread servings so you can have your carbohydrate and all this. She said, yes, baby. Yes, baby. Come to find out, she never had a dietitian talk to her. She didn't know what I was talking about. And she ended up going into having another problem wherein she actually went to the hospital, went into a coma. We couldn't even hardly find her doctors at the time. There was some issues of health equity, issues of, how our elderly are taken care of. And I was working at St. Louis Medical Center at the time, and I fought for her and actually got her transferred, got care given to her. But she was diagnosed with chronic renal disease, and she had to be on transplant. Needless to say, she was very, 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 very heavy. And I can say this, that I felt that through my advocacy, I was able to help her have at least 6 more months of life. But she died of kidney disease because she bottomed out after kidney dialysis. I also have a brother right now, and that's usually not what part of my story, but from my experience with her, not seeing a dietitian, that made me go into public health, because I wanted everyone to hear about the importance of nutrition prior to having a problem. But my brother, he had high blood pressure. When he got COVID, he used to we tried to get him to go to the doctor, he wouldn't. But he did get COVID. After COVID, they found out he had stage 4, a kidney mass, stage 4 in his kidney, and had to have a kidney removal. And now I work with him on his diet. He goes to the doctor religiously. He's doing well. He's probably it's been about 4 years post, well, 3.5 years post his kidney removal, doing well and eating healthier. All I'm saying is that sometimes we don't realize that it's you need to start thinking about it before it happens. But even once you start having issues, once you've been diagnosed, you still need to eat for life. You need to eat for longevity. And so I'm a public health dietitian. I do this disclaimer because I'm at a kidney talk. I am not a clinical dietitian. When I first graduated, that's all I wanted to be. But because of these things, I went into public health. And so people call me all the time. Oh, they say I need to do this, do that, the other. I will tell them, first of all, make sure you have a dietitian you're working with that can go and see your labs and really personalize the diet to you. That's one key. But I also say, if you just don't feel comfortable, go get those lab numbers and bring them to me. And I will help you to figure out what they mean, because people need to know their numbers. So next slide. So here's my opening statement. The importance of, and you read it along with me, the importance of healthy eating and nutritional intake has been recognized as key factors for prevention, treatment, and management of chronic diseases, including those involving the kidney. All body systems are connected. So eating to keep the entire body healthy is key. Next slide. With this slide, I wanted to show you how, if you're talking about different body systems, you will see that, your blood flow is important, so that your kidneys are affected from blood flow from your heart, and you're having healthy vessels, keeping the blood pressure under control and arteries clear and healthy. Blood sugar levels in normal ranges and pancreas functioning, and all accompanied by maintaining a healthy weight, healthy eating, and regular physical activity. These are things that we know. But again, there's obstacles along the way. In the talk that the doctor just did, she talked about food deserts. Some of the new dietitians have new words for a lot of the things that we see in our community. And I just wanted to bring those up. One of them is food swamp. Have you ever heard of a food swamp? They're now saying what we call food deserts might not be a desert, meaning that there may be food in that area, but a food swamp is having at least 4 or more fast foods and unhealthy foods to one healthy food outlet. And if you think about the number of healthy full service grocery stores in the inner city, and the amount of fast foods, you can see that they say we may have many food swamps where you're getting food, but it's not high quality food. So can you think of some food swamps in your area? Next slide. Another term they're using is food apartheid, meaning the healthiest grocery stores are apart from the community. Like people who want to shop at Woodman's, or you have to go way out to some of the higher end pick and saves to get the full range of healthy foods because they're not in the inner city. So now you're talking about food apartheid. And again, food justice is another term saying that we need to fight for more just food policies. And that is exactly, trying to get healthier foods into the community. But one of the good news I wanted to bring out is that as people change to healthier eating and healthier lifestyles, the risk and the complications from chronic diseases and comorbidities go down, and they have studies to show this. One major one was the diabetes clinical control trials, diabetes prevention programs that show as you change to healthier ways of eating. And in some of these, when they looked at regular physical activity, they looked at 1 or 2 times a week walking. It wasn't even the whole 3 times a week. They're saying even you get out and walk 1 time a week, or if you change your weight, only 5 to 7%. They found that your risk from some of these chronic issues, and I did highlight risk of chronic kidney disease, went down dramatically. Another research that I just looked at, because I really am looking at longevity, one of the research said that at any age, you can increase your life expectancy by changing your eating habits at that time. Like at 20 years old in that age, if you're eating healthy, you might add at least 13 more years on to life expectancy. At 80 years old, you may add on another 5 to 6 years. Well, somebody said 80 years. Well, if you already made it to 80, having at least another 5 or 6 years when you can see your grandkids graduate from high school, oh, that's valuable. So healthy eating can make a difference. But even after kidney diagnosis, you've already seen that the management of it and really getting to understand your particular numbers, your particular issues, you can manage that, but you have to get involved and you have to know the numbers. So that's why I was really happy to hear that one, the young lady that talked about her depression and how she moved into knowledge made a big difference, you know. And so but you can't run from it, hide from it, be afraid from it. And although you can pray and be more at peace, you still need to be proactive and do the things that you need to do. So next slide. I'm going to just go through a few things because if I had more time, this is what I usually do in some of my presentations. I talk about, you know, the idea that you could make your healthy eating plan, meaning that you could take the time and do the things to personalize your diet because it's all about you. So I could talk nutrition all day. You can read a book all day, but it also means it's what you put into your mouth and how you plan on your lifestyle around eating. So self-reflection, self-assessment, and then making those plans. I see I have two of them at the same thing, but the self-acceptance means that you have to accept that you have to change. You have to accept you have to change. The assessment is getting to know what you eat, why you're picking it. And then self-reflection is developing a realistic plan for eating for health. And it does mean for some people really figuring out what kind of budget do I have? Where can I get the healthier foods on a lower budget? You know, some of these is realities that people need to face. Even some of the food pantries are now starting to say we got to serve healthier food items. There are choice food pantries, meaning you shop like you're in a supermarket and they have fresh fruits and vegetables. So this is very important. Next slide. This nutrition eating for life, I threw this in there because sometimes people say, but I can't change. That food is like love. Food is a comfort. Food is survival. You know, when you say, well, it doesn't make a difference what you eat, you could just eat anything. No, after a while, it doesn't make a difference what you eat. And you should try to find the places that you can eat healthy or help people find healthier places to eat. Healthy makeovers, I'll talk about that as far as traditional foods because our cultural foods make a difference. We have a bond to those. And if you ignore the bond, you're going to miss an opportunity to help people move to a healthier way of eating. But you still have to be able to know how to pivot that person into the right type of eating style that's going to help them to survive. Next slide. I wanted to bring up some healthy foods. When looking at chronic kidney disease in the past, because I used to be a clinical dietitian when I first got out of school, I never wanted to be anything else but a clinical dietitian. One of the things, the diet for even kidney disease had been more liberalized over time because they found out having those really restricted diets that you restrict everything was not healthy. You get kidney disease and it doesn't mean you don't need the nutrients that you need for a healthy heart. You still need the nutrients that you need to keep your body and your muscles and your, strong and healthy, even the blood, like your iron. You still need those. So when we were restricting people so strictly in potassium levels and sodium levels and fluid levels and all of these levels we were restricting them on, the diet became very poor in nutrition. I was just at the Academy of Nutrition and Dietetics program recently, and they had a whole kidney disease program, and they said dietitians got to get out of their own way. And I was like, what does she mean? They're saying that because things have changed in the knowledge of nutrition and health, they found that there was no real reasons to restrict all of your fruits to only a certain fruit, all of your vegetables to only certain vegetables, dialyzing your potatoes to the point where they taste like water. Uh, and, and I don't know if anyone know what dialyzing potatoes is, but you chopping them up, fresh potatoes really small, you put them in water and you let them sit overnight, and the potassium is supposed to leach out of the potato. Then you drain all that water off, and then you can mash those potatoes and eat those potatoes. Well, but they do taste like mushy water after. So, yes, you do have to watch potassium. Some of the new research is saying it's the elemental potassium that's really causing more of a problem. So that those processed foods and also things that say it's low sodium but has potassium salts in there. Medications that may have potassium salts, people might be taking something over the counter that has a potassium salt in it. So really evaluating those, but in essence, a diet could be more liberalized so that, you can have some tomatoes, even though you have kidney disease, you can have some tomatoes, so these are the types of things they're saying. We got to get people back to eating the colors of the rainbow. We have to get people back to having a realistic, healthy eating pattern that is going to help keep all of those other body processes together, even if your kidneys have not, you no longer have the kidney function like you used to. Next slide. I would go through phytochemicals, healthy phytochemicals. I'm not going to go through all of that. We know that they are very healthy, help prevent cancer. Even kidney patients have to not eat away when they're not having a high diet that is going to be cancer promoting, and getting some of those cancer reducing foods in. Again, the diet has been liberalized where you should be able to still have something like broccoli and cabbage on a kidney diet. You may have to, when I did ask about the cultural foods, can we have our greens, our sweet potatoes, and also our cornbread? They say, well, you may have to watch your portions. You may have to look at the combination, but it doesn't mean that, with good management that you would not be able to have those types of things. Next slide. Okay, this is where, I've said it once before that for maintaining your health, adequate protein and nutrient dense foods. You still need adequate protein and you still need nutrient dense foods that lower blood pressure, and also healthy foods that is good for your gut microbiome. And then also looking at moderate levels of sodium. Many people are thinking that it's the salt that you use at the table. It's the sodium infused in all other things. If you get into cooking healthy foods, you can kind of control what's being put in your diet. The thing about it is like you said, depending upon who is getting it, there's a lot of education. There's a lot of education that has to be done around nutrition. There's a lot of young people who are into nutrition. The idea of trying to get them to really understand it before they have a problem is important. But as they said, young men make great cooks though. Don't think that if you really get into getting men to embrace healthy eating that they can't do it. They can do it. It's just that sometimes taking that time and also making it so that they can get the resources they need. And there's a lot of different ways that they actually could, but they're saying many times women are used to going to systems because they got WIC, they have other systems. They're used to getting that assistance. Young men sometimes shy away from it. And they are sometimes go without, not understanding that they too are eligible to get assistance and get, food vouchers and things like that. So, making sure they understand their options is very important. The magnesium, the calcium intake, even with the idea that you have to monitor calcium, it's not that you can't have any. So that is very important because sometimes the misconception means that you're now still developing a diet where you don't get any magnesium, you don't get any of the nutrients that you need. And so that's where the balance comes in. And that's why I always say, make sure you are checking and have seen a dietitian that can tell you and give you the advice and make a diet plan for you. You just don't know how many people come to me because, first of all, sometimes they do not trust the dietitian. So if they don't trust you, they're not going to follow you. And then people say, come talk to me. And I'll tell them, well, I'm not a clinical dietitian. And they don't understand what that means. And I try to make them understand that you have to have a diet personalized to you. So these are some general tips, but also the personalization is important. So you know exactly which one you should be following. But the processed foods for everyone is not good. So if somebody is just eating bologna and hot dogs all the time, you're not getting the nutrition that you need and you're getting something that's going to be harmful at the same time. So changing up how you eat and what you eat is going to be. I'm going to see if it came back. Next slide. With the soul food diet, I just wanted to mention that there are makeovers that you can do, and you can make it with healthier ingredients. And there's so many ways to do that, and helpful ways to do that by changing maybe some of the fats that you use, changing the amount of sodium that you use, making sure you're not using a lot of salt sources in your cooking. Give you an idea. When my brother came, I always use real examples. My brother came, lived with me from Indiana, moved back here. He brought his seasonings with him where he's a good cook. He's a very good cook. But then I was in the kitchen with him. He was using seasoning salt, onion salt, garlic salt. And I was like, don't you want to use some of them powders? He said, you eat the way you eat, I'll eat the way I eat. After having a kidney diagnosis, kidney removed, he eating them powders. He's telling me, don't put that salt in my food. He's changing. He's stricter than me. All I'm saying is people can't adjust because you still have flavor in your food. He's sauteing fresh mushrooms, fresh onion. You come in there and it's smelling like, oh my God. People can change, but they have to really be kind of made aware. Sometimes I do food demonstrations just to let them know healthy food can be delicious. It doesn't have to be what they call rabbit food. So healthy makeovers is important. Next slide. And I'm almost at the end. I just wanted to show you some of the cultural foods that some people say, oh, that is soul foods are unhealthy. Your greens have 350 milligrams of calcium in it, as much as a cup of milk. Now, you may have to kind of measure and, restrict how much you eat at one time, but they are healthy. They also are high in iron, one of the most absorbable iron. So you get healthy ingredients. Sweet potatoes high in beta carotene. So you're getting healthy beta carotene that is very good for your skin, for your immune system. When you look at your black eyed peas, They're high in soluble fiber. Those also are high in phosphorus. So you may have to balance how much you have, especially if you're looking at combinations. But usually you don't have to cut them out. I mean, much of the research is saying you don't have to cut everything out. You have to manage it. And technically, some people don't eat black eyed peas every day. It's just a thought, oh, I can't have black eyed peas. And then, people say they crave. So I try to tell people you can control what you have to, but you don't have to think you can never taste them at all. And then you have your catfish is high in omega-3, almost like salmon. So it's just bacon, roasting, broiling would be a better way. Put some lemon on there, still gonna taste good. Watermelon high in lycopene, just like your tomatoes. And then you have your green and red cabbage that's known for lowering cancer risks, just like your broccoli. So the foods, you ever heard of food is medicine? That your foods can actually be working to keep you healthy. As the kidneys are not functioning, that's a key place that you need to balance out things in your body. So learning that balance is so important, but knowing that you doesn't mean that you don't need the nutrients. You just need to make sure you know what the balance is. Next slide. And this is my last slide. One of the things I wanted to let people know is that I have done a podcast series called Back to the Kitchen, wherein we've talked about healthy cooking. I've got recipes, that all sorts of healthy recipes that's been demonstrated. That's something that you can go to, but also making sure that if you're looking at certain people who need extra help, there is actual classes that can be developed. You've got UW Extension Office that has been doing some things, and then I'm available to do food demonstrations and that type of thing. But just keep in mind that healthy eating is central to a healthy body. And as you start talking about your kidneys, I have know some people who have lived as much, well, they're still living, but they 15 years ago diagnosed and been on kidney dialysis for that long a time. Not everybody takes to it as well, but I know that this person is a pastor, been doing well, and the biggest thing I say is acceptance. And I find that with nutrition, acceptance of healthy eating, and that it's okay that you'll love the healthy eating once you made that switch from having the processed foods. Some people say it's easier to cook unhealthy foods because you got to do work. But after a while, you get so into it that you do not want anything else. So people say, well, what you eat? That picture is from my kitchen. One of my favorite foods is a chicken stir fry. And having those vegetables cut up, a stir fry goes so fast. Once you've said it's in the next 15 minutes, you'll have the whole meal done, and it's just so tasty. So with that, I'm going to turn it back over.
We have time for a few questions. Does anyone have great? Dr. Greer, you made a point of saying, in fact, let me ask. Passed by the gentleman. She said, men cook. You cook? Tell me, what kind of things do you cooking for yourself?
Stir fry.
Nah, come on, she just said that. That's why you said
With steak,
Uh-huh.
steak and vegetables, chicken, ribs, a barbecue.
All right, good. Barbecue, okay, good enough. Now, so Dr. Williams, if you're still out there for me,
I'm here.
All right.
yes.
how much time does the average physician spend talking about dietary changes that patients should make?
The average physician?
Yeah, when we talk about a patient with renal disease, how much time do we spend time talking to the patient about foods and
No.
things they should eat?
No, I would say that the amount of time that an average physician spends talking to a patient about dietary pieces is negligible.
Yeah.
Physicians typically say, well, let's talk to our renal dietitian. But
Okay.
no.
So let me ask, Ms. Parker, you still there?
Yes, yes,
Okay.
sir.
In all of your experience as a renal patient, how many times have you been referred to either a dietitian or has the physician sat down and talked to you about
That
eating?
I do at my clinic, we do have a dietitian, but she does not talk to us about foods. We get handouts about it. We do get handouts, but nothing personalized.
Uh-huh. Okay. Tell me, has anyone ever talked to you about eating in particular foods? Did any of your doctors or healthcare workers ever talk to you about eating foods that you should or should not eat?
Yes.
Have you listened to them?
No.
Why did you not listen to them?
Somewhat I do, but
Yeah.
not all the way.
All right. So, Dr. Greer,
Yeah.
they've talked to her, but she doesn't listen all the time. What is the big stumbling block that you find? Because one of the things you did not mention, but sometimes not only does it, some people feel it takes longer to cook a healthy meal, but it costs a little bit more sometimes. Tell me about that.
Yeah. Um, Many times that's what people really feel, that it costs a lot more. However, when they, if you really cost out how much you get from what you buy, you actually get more servings out of the healthier food. And so that way, versus spending money for one item and it's gone, like a cabbage, you might can get 3-4 servings out of the
Mhm.
cabbage, even though, at the time that you buy it, it's going to be more
Yeah,
expensive.
but
So
I can go to the okay, I'm from Kentucky. So you can go to Kentucky Fried Chicken. I can get the 8-piece meal, I can get mashed potatoes and all that. Is it cheaper for me to go buy a chicken and cook it and then
it's
cook the
it,
legs
it
as opposed to doing that?
it's cheaper if so many times people are not looking at how many servings are getting out of it.
Right.
Technically, it is going to be cheaper if you cook from scratch than if you have the fast food, because the fast food is only there for 1 or 2 meals.
Okay.
The convenience is what is the issue.
All right,
And
so
if you're not if you're not
Okay.
used to, say for instance, you grow up in a household
Yeah.
that never cooks
Right.
from scratch.
Right.
You don't see it, you don't know it.
All right, hold that point. How many of you all here have a slow cooker at home? How many of you, keep your hands up, keep your hands up. How many of you use the slow cooker at home? Okay, what about an air fryer? All right. Now you were saying, all right, she was talking, you said, yeah, yeah, yeah. What were you yeah?
Well, I was saying that she's right about the cost of healthy food. So my sister, I won't say her name, but she buy a
You
lot of.
only have one sister, right?
No, I have more than one. Well, actually, she wouldn't care. But anyway, she has 5 children, so she buy a lot of healthy food, and I eat healthy. I'm a pescatarian, so I said to her, you guys gotta stop eating like that. You gotta stop buying all that fast food. And she was like, sister, it's so expensive to buy the healthy stuff. And so I started kind of helping.
Oh, now wait a minute. Now I'm an Episcopalian. What's a pescatarian?
A pescatarian is a person that eats
Fish.
like fish and seafood. So I don't eat like chicken and all this other meat.
All right,
Yeah.
Miss Parker, you still there?
Yes. Yes, sir.
One of the things we always hear about as far as patients with renal disease is you have to cut back on the amount of fluids that you're taking, right?
Yes.
And
It's 32 ounces.
Okay, and Dr. Williams showed us all these pills that people have to take. Now I'm going to assume you're not doing a dry swallow with these pills. How do you manage?
No.
How do you manage fluid intake when you have to take all those pills?
Basically, I just do sips. That's basically what I do.
Wait a
I
minute, in
try
Kentucky, what we have now, wait a minute,
not to
what's a
take
sip?
all the pills.
Tell me what's a sip? Because in Kentucky we have a sip of bourbon. That's a little different than I think you people are talking about up here. So what's a sip?
Yes, it's much different than that. But just a swallow, just a little bit of water with your pills. You're not going to take all 10 pills at the same time, but you can separate. I separate my binders because they're so big. But I do just sip, and I try to stay under 32 ounces.
All right, fair enough.
One,
So-
one thing I
Go,
wanted to
please.
say is that in the inner city,
Mhm.
many times the food, the some of the healthier foods is higher.
Mhm.
You go out to Woodman's, you go out to other places, and the the price of the food is much lower. So this idea of educating people of how they can get the lower cost foods, and then also the idea of looking at why is the food so high in the inner city, and being able to really advocate to try to change that. Because again, if you don't have any supermarkets in the neighborhood, and you just go into the corner store, those foods may be higher in cost and lower in quality.
Let me ask you something then. So tell me, what is the big difference between my buying frozen food versus buying a canned food? And if I'm buying canned, something that's canned in water, canned in low syrup, canned in high syrup.
Well, I mean, there can be differences between all of those, you know. So yes, there's differences because
Which one should I choose?
well, we usually say you should always use fresh best.
Yeah.
However, you know, if you can't get fresh, then you should, you know, frozen and then canned. But what happens is that you have nutrients in all of them, but there is like a 5 to 10% difference if you get the can. So in a nutrition world, you can use all of them, but they may have different sodium values. When you get fresh, you don't have any extra sodium added. You control it totally. As you get, even some of the frozen may have sodium,
Okay.
or some of the can may have sodium.
I got a question over here. Our person who doesn't listen when she gets asked told. Go ahead, man.
Wait a minute now. I have like 3 health problems. Now, one of the medicine that I take, I make me lose weight, and I'm losing weight. To me, I'm losing too much weight because the food the medicine that I take, it makes me lose my appetite. So one of those, what can I do about that?
Well, I'm gonna tell you what you do right now. Dr. Williams, tell me if I'm wrong. She's taking a medication. She says it makes her lose her appetite. The first stop she ought to make is where?
Her doctor.
Thank you. What did your doctor say when you told him that?
Well, the medicine that they're giving me, they know it.
Yeah. Here's the choice. I want to ask somebody. I'm going to ask a guy here in the audience. No, hold on. You get. Oh, wait. No, I'm coming. I want to hear something. I want to hear something there. If this is Dr. Larry Sanders, he used to be president of the National Medical Association. He's one of them big time doctors. So don't worry about it. So if a patient comes and tells you that they're having a problem with a medication, what do you tell them to do?
Well, first of all, we're going to talk about it. And if the medication is causing you a problem, we're going to find you a new medication.
So if you're not happy with the medication, that's his point. Something is going on. So you need to talk to your doc and say, hey, we got to find, because believe it or not, I think Dr. Williams showed us there are a whole bunch of different medications in a pharmacy.
Okay, what I wanted to say now, when I was,
You ready to dance?
that's what I'm going to tell you. When I was built,
I think anybody under the age of 50 needs to leave because it's going to be a good conversation right here.
wait a minute, when I was built and I had that figure, I didn't worry about my appetite because my appetite was all right then. So now, what I'm eating now it made me lose my figure that I had. And I didn't want to lose all of it now. I wanted to keep some of it.
I got to go on that one. I think what is clear though. So, okay, here's the thing. So she wants to try to find, and this is going to be our last comment before we turn things back over to Pastor Fields. So she wants a dietary pattern where she can lose the bad stuff, but keep the good stuff, if you know what I mean.
And one of the things
She wants to keep
is that
her ticket good. Okay, so go ahead.
one of the things is that, you know, aside, even with talking to the doctor, if you develop a relationship with the dietitian, you can really let them know as well what you're doing. Because if you're doing, many times you have to do like a food recall or an assessment to see what is it that you actually are eating, and you can get tips on what else you can add, what else you can do, or how you can change up the timing of when you take medication. Maybe it may be that you eat at a certain time and then take the medication wherein you're not, at a time wherein it's affecting your appetite.
Now,
So that's one thing. But the combinations of foods that you eat is very important, and the timing of when you eat them is very important. That's why I always say you have to have an individualized plan. And sometimes if you only meet with the dietitian once, you would never get that plan.
we got one more. I'm a sucker for a pretty face. So go ahead, please. Tell us, what is the question? You're not going to start shaking and wiggling like she did, are you? Okay.
How many fruits and vegetables do you suggest per day?
Okay. When they start looking at fruits and vegetables, they used to say a minimum of 5 fruits and vegetables a day, like 3 vegetables and 2 fruits. When you're looking at cancer prevention, now they're saying you should have a total of at least 9, 5 to 9 a day. So it can be done. It can be done. Just think, okay, breakfast, if you have a fruited breakfast and put some spinach and stuff in your omelet, that's 2 fruit. That's a fruit and vegetable. That's 2 right there. If you go to lunch and you have a salad, you have a vegetables, that's 2 more. If you have a snack of some fruit in between, that's 5. Now you're talking about your dinner. You can have salad, 2 vegetables, and then 1 in the evening. Meaning 1 something as a snack. You can get up to that amount. It doesn't. So many times when we think of 1 fruit serving, it's smaller than what you think. So if you're talking about a half a cup, you may eat a whole cup of the same thing. It doesn't have to be different. What I usually do is I cut up my fruit and put it in my salad. I'm not having everything separate. I'm combining them when I have a salad, it's going to have my fruit and my salad in the same thing. So then it seems like I'm having 1 item, but I'm actually having 2. Then if I have a cooked vegetable, that's 3 at 1 meal.
Right.
You can get it in if you start thinking about those
5 to 7
combinations.
So 5 to 7 servings of fruits and/or vegetables every day. Ms. Tonya Phillips, please come up. You wanted to make a presentation. Thank you very much. Thank you, Dr. Williams. Thank you, Ms. Parker, and thank you, Dr. Greer. Just put it back. Let's go back. Go back. Go back.
So I'm Tanya Phillips. I helped coordinate tonight's efforts and tomorrow. And I reached out to Superintendent Fields and he connected me with this beautiful lady who's coming forward. She has been an outstanding partner in the collaboration of efforts. Everything that we needed, she was on top of it, always with a smile on her face, always wanting to know if she could do more. And so this is just a small token, Miss Wilson. This certificate acknowledges Deon Wilson's support and partnership in coordinating the June 19th and 20th, 2024 Milwaukee Protect Health Equity and Kidney Care Community Conversation. We are thankful for your service.
Y'all heard it. So if you need our help, we're here.
Thank you. Thank you, Superintendent.
I'd like to again remind everybody, if you've not filled out your post survey, now is the time to do that. Also, be sure you filled out the pre-survey to conclude the program and introduce the final speaker. I'm going to bring Pastor Fields up, and thank you for everybody. And, oh, by the way, how about a hand for Mr. Cole? He handled the Zoom and all this. Magnificent. Well done, sir. Well done. Pastor Fields. Thank you, sir.
Once again, thank you all for coming today, but it's not over. It's not over. We're going to come back in the morning and hear what we would typically say in the church, the conclusion of the matter. I really enjoyed myself, and this really has been educational to me. There's so much information that has been given to us. We want to take the time to really review everything we've received tonight, and then also come back on tomorrow and enjoy and take even the more. Tell somebody about what we've learned tonight. So we had many registrants and we have many no-shows. It's because sometimes we know some things come up, but oftentimes people just don't take their health serious until something goes wrong. So please tell someone, bring someone with you tomorrow so that they can get this information. We'll have many other guests tomorrow. Thank you, Dr. Greer. You did a wonderful job, and we so appreciate you. So I'm done. We're going upstairs to district missionary. You want district missionary Dr. Ora McGahee to give us a prayer out of here. Mama, make sure you pray about this room that he was talking about. And there you go.
Certainly, I did enjoy all of the presentations, all of the questions and the answers. It was a delight. We were certainly infused with more information. Father, in the name of Jesus, God, we thank you right now. Thank you for this session. Thank you for the education that we have gotten on this evening from these dynamic speakers. Give us hearts and minds opened to hear, to implement the things that would help us to have a healthy life. Thank you for this open door. Thank you for this pastor. They've allowed us to come and be able to hear the dynamic words of these thy speakers. Now, Lord, bless us as we leave this place, but not your presence. Lead, guide, and direct us. Help us now to be the people and individuals that will always bring positivity one to another. In Jesus' name we do pray. Amen and amen.
Wonderful.